Hey everybody, it's Dr. Leith, and today I'm going to go over neurodevelopmental disorders, neurocognitive disorders, and the dissociative disorders. So let's jump into it. Oh boy, guys get to watch me struggle with my PowerPoint yet again. Oh man, I gotta take us all the way back. Alright, neurodevelopmental disorders. This is the first section in your DSM. And these are primarily diagnosed in childhood and adolescence. In fact, in previous editions of the DSM, this would have been referred to as disorders of childhood and infancy. So these are very dependent on developmental milestones, right? Walking, talking, sleeping through the night, things like that. So we would typically see them in younger clients with parents or caregivers bringing the child to counseling, bringing them to a pediatrician who then refers to counseling and things like that. So this section is pretty dependent on the context of we're working with a child, and with that we have to readjust how we gather information and how we interpret information. Some things to consider when working with children is that they have very limited self-understanding, meaning that when you ask, how are you, what is that like, tell me more, they have very limited ways of conveying what they're going through. So if you suspected a child of maybe having difficulty with reading or social interaction or maintaining attention, how do you expect them to answer, right? And so that's difficult. However, it's remedied by, one, getting experience, and two, adjusting the way we communicate and understanding that we might have to ask many clarifying questions of children to understand, and we'll probably have to talk to parents or teachers or other caregivers. They live in the here and now, so it's very easy to get information from them about what's going on right here, right now, but it is a little more difficult for them to communicate experiences from the past or what they think future experiences will be. And that's developmentally normal, right? All of these are normal. It just takes adjusting on the counselor's part to understand that children lack a really strong ability to communicate certain things, and we expect that to get better as they age. Unrealistic ideas and explanations. So magical thinking, right? You've heard that term. Think to your human development course, and it's things like, if I do well in school, mom and dad will stop fighting. If I do this, then this thing will happen. I'm invulnerable. People don't die. Things like that. And so when asking, about cause and effect type situations, you might see some of that magical thinking. They're very dependent on other people. That's what children do, right? They just sort of leech off of you. I'm just joking. They depend on other people, right? So that plays a role both in the sense of communication with the counselor and also their living condition, that they are dependent on others. And they lack experience, right? So sometimes the younger they are, when they say this is the worst day of my life, it might very well be, right? This is the greatest pain I've ever experienced. But this also helps with resiliency, right? They're not beat down by the weight of the world. So, as I was saying, in this section, the distinguishing feature of these diagnoses is that we're basing it on their development, meaning that at certain ages, we expect them to accomplish certain things, as I mentioned before: walking, talking, potty training, communication, sleeping through the night, taking care of oneself. So this is based on comparisons to their same-aged peers. And we notice problems when the child is not meeting those milestones. So, as I mentioned before, working with children, we have to work in a different way to get information. So when doing an assessment with children, we might be asking about those developmental milestones, asking at what age did they do this? Have they ever done this? Do they maintain eye contact? What is their vocabulary like, right? We expect the younger they are, the younger a child is, the smaller their vocabulary, and we expect those to scale up together. Language impairments, right? And this might be how they speak. A child who's very young might say, I run to the store instead of I ran to the store, and that's normal. As they get older, we would expect the language to improve. Can they make relationships? Do they have appropriate social interaction? Control of their body, right? So when little ones start to first walk, they're waddling around, they walk like a newborn deer, they're bumping into things, but we expect their articulation of their body to improve with their age. Do they seem more active, hyperactive, or less active, more impulsive, less impulsive than their same-aged peers? And do they do anything unusual? Meaning, if you lined up like 100 kids, their same age, are they doing something that 51 of the other children would not do? And again, as I mentioned in the previous video, fire setting and cruelty to animals is always a red flag. Doesn't always mean for what, it just means it's a red flag for something. So let's start this discussion with the first disorder that they list, which is intellectual disability disorder. This is what was previously referred to as mental retardation. We no longer use that term, right, for diagnosis. We now say intellectual disability. And this is something that you would diagnose before age 18. And chances are the signs of it would manifest much sooner than 18. They would manifest before going to school and certainly within school. And this is a disorder where the person has a lack of intelligence. And we specify, remember I said before that the DSM has different severity specifiers, right? This one has mild, moderate, severe, and profound, right? So let's look a little bit more. A couple things I want y'all to know. One is that there's different domains, that they have deficits intellectually and adaptively in conceptual, social, and practical domains. So conceptual, their ability to form ideas and how they think things will happen. So a really good barometer is cause and effect, right? Understanding what causes this. If I do this, it'll make someone upset. If I do this, the thing will break, whatever it might be. Socially, right? So relationally. And practical, living on their own, right? Being able to get dressed, to clean oneself, to feed oneself, and so on. And the three criteria are there must be a deficit in reasoning, problem solving, planning, etc. And I highlight this because it's really important. It's confirmed by a clinical assessment, so your interaction with the client, and an individualized, standardized intelligence test. So what does this mean? That means that you cannot just diagnose this, you have to give an IQ test. And it has to be a legit one. Like, you can't Google IQ test and then just take whichever one, like from BuzzFeed, that comes up and asks you a bunch of questions, right? So we're talking about like the Wechsler, the Kaufman, things like that. You're giving a standardized, time-tested, reliable, valid IQ test that has been standardized. And that helps discern where they should be, and if it's truly intellectual disability, or is it, borderline intellectual disability? Is it a problem in some aspect of intelligence? Is it a really specific area, like with math and working with numbers, or is it a memory issue? But giving an intelligence test helps us understand where the issue might be, or is it truly intellectual disability? The deficits result in failure to meet developmental and sociocultural standards, right? So again, a child, a 4-year-old, will probably fail or score very low on an IQ test because they're 4. That's normal, right? And then different cultures have different expectations for those developmental milestones, so we take that into consideration. As I mentioned before, you would specify mild, moderate, severe, and profound, and there's a table in the following pages that gives you examples of each. With mild being they're able to care for themselves, they need some support, and profound being that they need 24-hour care. This would be someone who left unattended might not be able to feed themselves. Global developmental delay is a diagnosis reserved for individuals under 5 years old, because you can't give an IQ test to a child that's younger than like 6, I think. And so you, a pediatrician or parents might see signs of a developmental delay, right? They're not walking, they're not talking. And so it's not specific enough to say that it's maybe selective mutism or something like that. We're seeing it in a number of areas. And for more information, you can also check out my video on IQ testing. That's for my assessment section, but you can check that out. I feel like a real YouTuber saying that, like, check out my other video in the description below. But global developmental delay, right, is for younger ones, and they're not quite fitting in here with intellectual disability, and they don't quite fit the diagnoses for the other childhood disorders, selective mutism, or maybe the stereotypic movement disorder or coordination disorder and things like that. This is, again, we have a very young child that we think is not intellectually developing the same as other 3, 4, and 5-year-olds. We now move into the subsection known as learning disorders, and you've heard of these: dyslexia, dyscalculia, and dysgraphia. And so these are, you'll hear these referred to as specific learning disorders, because it's not a global delay, it's not a global intellectual disability. This is specific to reading, writing, arithmetic. And again, these diagnoses are made on the basis of a standardized individual test, right? To go back a second for IQ testing, and I go into this in much greater detail in my assessment videos, the cutoff score for this is 70, right? So a score of 70 and lower on an IQ test, standardized, again, not a state test like TAX or STARS or whatever we call it, and not just a random collection of questions, but a standardized, bona fide IQ test, a score of 70 or lower. Why 70? Well, in short, for an IQ test, the average, the mean, the average score for an IQ test is 100. And there's a standard deviation of 15. And I'm rushing through a whole lot. If you don't care about this, that's all right. You just need to remember that 70 and lower is the cutoff. A score of 70 would be 2 standard deviations below the mean. And long story short, that puts that score in the second percentile, meaning 98% of other same-age test takers scored higher than that client, right? So 70 is a very low score for an IQ test, and scoring lower would indicate even more problematic development with intelligence. So 70 and lower. Learning disorders, again, giving a standardized test, and let's look at these a little more. So impairment with reading, that's dyslexia, right? And so the person, despite maybe having an appropriate vocabulary and developing normally or as to be expected, it has a very difficult time with reading. And so you might hear a client say they can't make out the shapes of letters. You would see they might see a lot of the letters switching, so the E and the A here might switch, having a hard time not seeing the R and the E as a really big C, right? Not being able to make out the shapes, letters switching, and having a difficult time putting together what's on paper. And of course, this would trickle down into other aspects that would affect vocabulary development. It would affect writing, right? Because they might, if they're given a prompt such as write your answer in the block below, they might have a difficult time doing that. Lots of frustration and self-worth issues surrounding dyslexia. So different fonts, behavioral strategies, and different educational approaches to help with children who have dyslexia. Impairment in written expression, also known as dysgraphia. And this is a difficult time writing. And it's not the same as maybe having sloppy handwriting. This would be essentially, I know you want me to write the sentence, the cat is fast, and I know what each of those words is. I even know how to spell each of those words. When I put pen to paper, the articulation of writing, that's where the problem is. And so what we see is children really putting their arm, making that L shape, right? You put your forearm in front of you, like you're blocking someone's view, and writing. Not being able to make the symbols, the letters, right? And then misspelling. Impairment in math is dyscalculia. And I always make the joke in my classes, like, how many of you feel like this is you? And everybody raises their hand. That's why we went into counseling. But this is not the same as being bad at math. This is kind of a fundamental misunderstanding of numbers. So number sense, for example, would be things like if I say, I have 4 apples. You, in your mind's eye, in your head, you picture 1, 2, 3, 4 apples. A person with dyscalculia, though 4 does not mean anything, right? There is not an understanding of what 4 is, or 5, or 2. There's not an understanding of number order. What number comes after what? 1, 2, 3, 4, 5. There's not an understanding or a comprehension of what number is bigger. There's not an ability to do arithmetic or anything algebraic, so addition, subtraction, multiplying, dividing, because there's a lack of understanding what these numbers are. And there can be a lack of ability to understand what numbers look like, what the symbols are, like what the 2 looks like and what the 3 looks like. These are just kind of ideas that are out there that don't have meaning to them. And so again, with this would come different educational approaches to help understand what it looks like. We now move into a pervasive disorder, right? Pervasive developmental disorders. So autism spectrum. So one thing to notice, some of you may be aware that in the past there were individuals who were diagnosed with autism, and there are individuals diagnosed with Asperger's, right? Asperger's being a high-functioning form of autism. DSM-5 has omitted Asperger's, and it is likely that you may work with, now probably an adult, it's less likely to work with a child with Asperger's, but you might work with an adult who had a previous diagnosis of Asperger's, and then ultimately, with the work of a clinician, was either re-diagnosed as having a mild form of autism or no diagnosis at all. So you might hear that term, Asperger's, but it is not a diagnosable thing any longer. With autism, we're looking at a delay in the way one interacts with the world and interacts with other people. The DSM-5 breaks it down into 2 main criteria. The first one is persistent deficits in social communication and social interactions. So this is a difficult time having a conversation, reciprocating, understanding the ebb and flow of a conversation, reduced ability to engage with other people, the eye contact, how to initiate and respond, deficits in nonverbal communication, so body language, eye contact, facial expressions, and deficits in maintaining, creating, and understanding different relationships and the social contexts of them. And we specify the severity for this specific thing. Please hear me, because everybody makes this mistake on perhaps a final exam question where the answer is autism, that you need to specify severity 2 times. 1 for communication, and then 1 for what's on the next slide. But the first criterion here is with social communication and social interaction. The next one is restricted, repetitive patterns of behavior, interests, or activities. So having the stereotyped or repetitive motor movements, so this would be the rocking, head banging, biting, pinching, playing with toys in a certain way, the communication, echolalia, using phrases, insistence on sameness and reticence towards change, highly restricted and fixated interest, so it might be a very hyper-focused interest on Legos or building or modeling or whatever it might be, and absolutely no interest in anything else. In either hyper or hypo-reactivity to sensory input. So these would be the cases where children of autism, if things are too loud or if they don't like a certain light or a certain fabric, if you put them in clothes that aren't that same or in a room that has extra noise or extra light, it really bothers them. And then again, we specify severity for this, right? So you have to give severity twice. Here's the type of severity, and again, I mentioned at the very beginning the DSM-5 changes what severity looks like. For autism, you have level 1 requiring support, 2 requiring substantial support, and 3 requiring very substantial support. 1, here we have some inflexibility with the behaviors, inflexibility, and more than one context, difficulty switching between activities, but that implies that they can switch. Moving up here, they can't, they're inflexible. For communication, they can communicate, but it's difficult for them. It may feel awkward or uncomfortable for everyone, but they can do that. They're able to learn and work with the symptoms. And up here, it would be very difficult to communicate. We also specify, now look at this, very different from other diagnoses, with or without accompanying intellectual impairment, with or without language impairment. Right, so that means whether or not they have it, you're gonna specify, right? Is it associated with another neurodevelopmental, mental, or behavioral disorder? So if someone has that rocking, they might also be diagnosed with stereotypic movement disorder, associated with a known medical or genetic condition, and then with catatonia, which you may remember from the schizophrenia and depression lectures. Lots of misunderstandings about autism and lots of debate over what causes. We do know that this is a neurological impairment, so there is something within the brain. We know that this is very genetically influenced with older parents, specifically older dads, having a higher correlation with children of autism. Lots of room for research, lots of room for understanding, and definitely a big need to help children and adults with autism, because this is one that doesn't necessarily go away, but rather the symptoms are managed. This is very much a disorder that is focused on symptom management. So I've worked a lot with young adults who have autism. Right, they went through childhood and now they're in a college or university setting, and they're older, they're 18 and up, they're adults, and these symptoms are there. And they've learned how to work with most of them, specifically the communication aspect, but now they're in a new setting and maybe they're trying to make new friends or coordinate more grown-up relationships, whether they're romantic or friendly or professional, and unsure of how to do that. And so it's learning what is normal discomfort and kind of growing pains of entering into a job or a new relationship and making new friends, and how autism symptoms can kind of interfere with that and helping support them as well. Now let's move to ADHD. Everybody's heard about this. Very frequently diagnosed and very frequently misdiagnosed. And so here's a couple myths about ADHD. One is that if you give a child medication for ADHD and then they learn how to focus, then it must have been ADHD. Well, we know that's not true, because those medications, ADHD medication, works on just about everybody, right? If you give those stimulants to a child or an adult without ADHD, it has the same effect, right? So the efficacy of medication is not a good measure of if a person really has ADHD. That children outgrow ADHD in adolescence. I think this stems from the idea that once a teen hits puberty and they're kind of they're interested in dating, they're interested in hobbies, they're kind of gravitating away from mom and dad and things like that. It looks like they're very distracted, and they might be. Distraction is not the same as ADHD, right? So an adolescent might grow out of distraction, but if it's ADHD, that would persist into adulthood. That medication is always bad. That is not true. Please see my video on medications and things like that. Everybody has an opinion on medication, and there are times where there are people who are, I admit, very quick to jump to medication, and there are also people who are very slow to acknowledge that maybe talk therapy would be more efficient if medication was involved. It's not always bad, and it's also not always needed. Everybody is different. The severity of the symptoms are always different, and everybody's values are different. But to say anything is always bad, right? You know what they say about absolutes, that only the Sith use them. Individual counseling techniques are equal in efficacy to medication. No, right? As much as I want to say, look, counseling is just as powerful as medication, it's not. It's different, right? Medication, especially medication for ADHD, has an immediate effect, whereas counseling techniques and behavioral techniques, you got to have a session. The person has to practice them. We learn what works, what doesn't, rinse, wash, repeat. It does take time. That ADHD is caused by diet. All right. I think all we really know about diet and ADHD is that giving children fatty acids, right, like the fish oils and things like that, does seem to help mitigate some of the symptoms, but not to any extent that it would be equal to either medication or counseling. And yeah, if you give a kid like a ton of caffeine and sugar, I'm sure diet is going to affect their behavior, but ADHD is not caused by diet. So a lot of times people get frustrated with children, and when they see that the child's not paying attention or the child is active, then it must be ADHD. This is kind of a very brief overview of the development of it. In infancy, we have no reliable or valid way of assessing children for ADHD. So a colicky child that's up all night crying, we wouldn't say that's ADHD. We would just say, your kid cries a lot. In preschool, some of the symptoms start to manifest. Now again, we are comparing that child to other same-age childs. Again, twice in one lecture. Comparing that child to other same-age children, right? And do they seem more hyperactive compared to those same children? Do they seem inattentive compared to those same-age children? And same when they go to school age, 5 to 7. Right? This is where if they have it, it's probably starting to really manifest. Inattention would continue. They have a hard time focusing if they're not interested. So it looks like daydreaming, just kind of glazed over, not paying attention. Hyperactivity would continue. We might see a little bit of a dip due to the structure in school. In adolescence, the symptoms would be fully formed most likely or most of the time. Inattention looks like this is someone who their head's in the cloud all the time, but it would manifest through all their classes and even social interactions. Hyperactivity, they would be more active and more impulsive than their same-aged peers. And then for adults, ADHD can go into adulthood, and many times it could be the case that an adult has either been misdiagnosed in the sense that they got a different diagnosis than ADHD, or they never went to counseling, they were never diagnosed. It is exceedingly rare that an adult will begin to manifest ADHD symptoms late in life, right? So in other words, the older they become without symptoms, the less likely they are to get them. So, does ADHD exist in adults? Absolutely. Does it onset in adulthood? Very less likely, right? So let's look at the symptoms. I know this is a lot of information. I won't go through each of these. But for inattentive type, 6 or more of the following for at least 6 months. Again, Inconsistent with developmental level. So you can't, this is not in a vacuum. You have to compare to other same age peers. Fails to give close attention to details. Difficulty sustaining attention. Does not seem to listen. Does not follow through on instructions because they're not listening. They don't know what they are. Often has difficulty organizing tasks and activities. Avoids dislikes or is reluctant to engage tasks that require sustained mental effort. And again, you can see how it's easy to misdiagnose these things, right? How many of us currently avoid or dislike some of these things? Often loses things necessary for tasks, is easily distracted, and is forgetful. For hyperactivity, 6 or more symptoms, often fidgets or squirms in the seat. So again, this ambiguity, this vagueness of, well, what constitutes a fidget, right? Often leaves seat in situations when remaining seated is expected, runs about or climbs where it's inappropriate, unable to play or engage in leisure activities quietly, is often on the go, acting as driven by a motor, right? Can't sit still, talks excessively, blurts out answers, difficulty waiting his or her turn, interrupts or intrudes on others. Some of the associated characteristics, so these are not criteria, but these just also come with it. Poor organizational skills, so both for inattentive and hyperactive, it's difficult to organize. Immaturity, problem-solving skill deficit, social deficits, low self-esteem, dysthymia, social issues. And really what happens a lot with ADHD is that the idea of acting occurs and the person acts on it before that thought got processed by the part of the brain that says, is this a good idea or not? So oftentimes with ADHD, what happens is the idea occurs, they impulsively act, and then the thought of, I probably shouldn't have done that, happens. That hindsight, I shouldn't say hindsight, but that thought process, it's sort of like behavior comes before the thought, as opposed to someone without ADHD, they're listening to the teacher and they say, they go to the next slide and they start saying, I want you to read this, and the child with ADHD immediately answers the question, or they immediately start reading it out loud because the behavior occurred and then the thought of, oh, I was supposed to wait happens. And so that mechanism affects everywhere, right? So this is something, again, that is neurological in nature, that the thought process, or the process for thinking and acting is different. There is a delay for the thought to get processed by the brain before the behavior occurs. Motor skills disorders. So developmental coordination disorder, also known as dyspraxia. So again, I said that children, when they're young, they're learning how to use their bodies. So here, the client is slow to develop motor coordination. Stereotypic movement disorder is repetitive driven motor behavior. And here's a couple of videos that you can click off on my PowerPoint to check it out. But this would be rocking, head banging, self-biting, picking, things like that. Our tic disorders, Tourette's. So there's a lot of these, but they're pretty easy to understand. Tourette's, multiple vocal and motor tics. So a vocal tic would be someone who they're saying something or making a noise and it's out of their control. It just might be a chirp like boop, boop, throughout the day. Motor tics, this is the face twitching, shoulder jerking, things like that. They have both vocal and motor. Chronic motor or chronic vocal tic disorder is one or the other. Provisional tic disorder is when the tics have occurred no longer than 1 year, and then you have a not otherwise specified. And then rounding it out, we have the communication disorders. Language disorder occurs when a child does not have the vocabulary or the ability to speak that we would expect them to have for their age. So compared to their same age peers, they do not communicate as well. They do not have as robust a vocabulary or the ability to form correct sentences. And again, this would scale up with age. We're not expecting a 5-year-old to have perfect language skills, but we would expect them to communicate better than a 4 or 3-year-old. Speech sound disorder. So this is a child having a very difficult time making sounds for words, so not being able to form the sound for the letter L or R. And again, we expect young ones to have a difficult time making certain sounds, and we expect them to grow through that and get the ability to make the sounds and to articulate. These individuals are lacking that. Stuttering, the frequent disruption of normal fluency, whether it be repeating monosyllables, the pauses in speech. And social communication disorder, difficulty or inability to have social dialogue, communication with another in an appropriate way given the context. So if you want to take a break, this is a good time to take a break. I'm going to go into neurocognitive disorders, which is now on the other end of the lifetime that we'd expect to see as someone is older. Delirium is one of the first, or is the first diagnosis. So rapidly developing, so it happens very quickly, fluctuating state of reduced awareness. And so the client has a difficult time shifting or focusing attention, and one other defect in memory, orientation, or language, and the symptoms are not better explained by dementia. So here are those symptoms: a disturbance in attention, inability to direct, focus, sustain, shift attention, and awareness. Develops over a short period of time, represents a change from baseline, and there's an additional disturbance in cognition, whether it's memory, orientation, language, visuospatial, or perception. You would specify with delirium what the source would be, or if there's multiple sources. So for example, is this because the person is high or drunk? Was there an injury? Is there an illness? Where, if it is a substance, which substance is it that's causing the delirium? All right, here we go. All sorts of different things you would specify, and the DSM gives you those codes, right, for each of these things. Then we have major and mild neurocognitive disorder. This is also referred to as dementia. You can use the terms interchangeably. And so we are looking at a loss from a previous baseline, right? So someone who always had a difficult time focusing or knowing what they're doing, we would not say that it's dementia, right? So such as somebody who maybe has major or profound intellectual disability, or level 3 autism, or something like that, we wouldn't say that it's dementia because that has always been the baseline. Dementia occurs when there is a loss, when there is a regression from their previous level of functioning. And there's only two, right? There's major and there's mild. For major, and there's some, I shouldn't say subjectivity, but they give you a lot of room to judge this, evidence of significant cognitive decline from a previous level of performance in one or more cognitive domains, so attention, executive functioning, learning and memory, language, perceptual motor, or social cognition, based on concern of the individual, a knowledgeable informant, or the clinician that there's been a significant decline or substantial impairment in cognitive performance, based on preferably neuropsychological testing or a quantified clinical assessment. And the cognitive deficits interfere with independence in everyday activities. So this is so severe that it's affecting their ability to live on their own in everyday activities. As opposed to mild, where it says evidence of modest decline, and everything else is the same, but the symptoms do not interfere with the capacity to live independently, right? So major if they need an extra caretaker or caregiver, right, to help them with it. Mild if they don't. They have it, and this might be they're always losing their keys or they can't focus on a task, and this would be that we fear for their safety left on their own. And you would specify, where did it come from? Is it due to late stage AIDS, Lewy body disease, things like that. And then if you need another break, this would be a good time to take that second break as I go into dissociative disorders. So dementia, the key focus was the inability to focus or shift focus and awareness. Here with amnesia, the focus is, or the emphasis is on lack of memory. And the lack of memory is not based on, they're high right now, so they don't remember anything. Or they were high when they did something and don't recall this. This is an inability to recall key details or memories from one's life. Where did they grow up? How old are they? What's their name? What are their parents' names? And it can be localized, generalized, systematic, excuse me, or continuous. Memory is the most affected cognitive function. There is no requirement, again, for the reduced ability to focus or shift attention. That's what separates amnesia from dementia, or from dementia and delirium. Specify if with fugue, right? So the purposeful travel of bewildered wandering. So they are purposely leaving. They're off to go somewhere, and they're not really sure, and they don't really recall key details about their life. So they don't recall, I have a job, I have family, and things like that, and they're out there and they have a destination, or they know they're traveling, as opposed to just wandering aimlessly, which would be indicative probably more of dementia. Again, consider age-related decline, that it's normal for memory skills and memory details to fade with age, and that's not what we're talking about. Decline is normal. When they're forgetting key details, key facts, then we start to think maybe there is something going on here. Dissociative identity disorder, also known as multiple personalities. Every time I go to a conference or to a talk about this, there's always a group of people there's one group who swears it exists, and there's a group that swears it does not. It is rare. I do think that it exists. And it manifests as a person having two or more distinct personalities. And so we're not talking about someone who who changes moods, or they change their style all the time. This would be a different personality is driving the behavior, a distinctly different person in the same body. The client would have a gap in memory or knowledge, right? Because as the alter, the other personality, the alter, when they are present, the primary person, your client, is not generating the memories or knowledge that the alter is. So your client might be missing remote memories. They might have lapses in dependable memory. Someone might say, oh, you're a wonderful artist, and the person doesn't know what they're talking about and doesn't know how to draw, because it's the alter that is able to draw and remembers that. And they find evidence of action, such as, why is there all this art supplies in my house, but I have no recollection of buying art supplies? There's a great article I posted, qualitative in nature, where there's a lot of interviews done, so check that out to learn more about it. It's a really fascinating set of symptoms, and if you have questions or thoughts about it, let me know. And then new to the DSM, depersonalization and derealization. You'll recall these as specifiers for maybe PTSD. Depersonalization disorder is when the person feels like they're having an out-of-body experience. They feel that they're detached and watching what's happening. And derealization is feeling as though they're in a dream. This is not really happening. And there are auditory and visual symptoms, right? Time is moving very slow. Sounds are magnified or I don't know if dullened is the word, but made dull. A key feature, though, is that reality testing remains intact. So in other words, the person knows who they are, when it is, where they are, and what's going on, but they either feel like they're not in their body, or they feel like this is a dream, this is not really happening. And that's going to do it for this week. I hope everyone's doing well. I know that was a lot of information. Check out those symptoms. Make sure you look at the specifiers for those. If you have questions, thoughts, or concerns, let me know. I hope everyone's doing well, and I'll see you in the next video. Bye-bye.